And we will now have a panel discussion for which we ask you to stay on. The convener of this evening's obesity agenda is Dr. Osama Hamdi, and he is joined us. And I would request that Dr. Osama Hamdi also joins this panel discussion. And I would also ask Dr. Sanjay Agarwal to come here and chair this session along with me for the panel discussion. So, Dr. Osama, would you like to ask the first question?
You know, first, I enjoyed every talk that had been presented so far. Very eloquent and very nice information. I have few questions for each one of the team, but I will start with Judy and ask Judy. We know that phentermine in the US is approved only for 3 months. I know that other countries are 6 months or more. Dr. Abovian was also confirming that. So do you have experience using it for a long time in higher dose in your patients? And what is your experience?
Sure. So it depends what you consider higher dose. So I think for me, that's the gray area. So I would use, say 15 milligrams once or twice a day for the long term. I would use that for greater than 6 months with or without topiramate. I wouldn't use 30 or 37.5 3 times daily in the long term because of cardiovascular side effect risks. However, I will say that by, I think an advantage of using a more modest dose, say 15 milligrams once or twice a day ongoing, is that there is still, it doesn't give you such severe appetite suppression that behavioral change is, really not part of the equation, because you still have hunger, right? You're still having hunger that you're going to have to use all the behavioral changes that we heard about to, in addition to lifestyle change, to maintain weight loss. And so, the problem is if you use a really heavy hammer, like 30 or 37.5 3 times a day, it's not really, it's not that hard to have, hard in quotes, to have behavioral change because you have such significant appetite suppression. And then when you stop it, people have a really hard time, and the weight rebound is often very, very quick and very robust. But if you are having a lower dose of phentermine to sort of take the edge off the cravings, like maybe at night, maybe later in the afternoon, and often when I tell patients that, they even do titration, like they don't necessarily want to take so much to completely suppress appetite. So they may decide certain days that are going to take it once or twice, depending upon, what's going on with their life. So I do that sometimes.
Right.
Jody, I think you meant phentermine 8 milligrams 3 times a day. Phentermine 37.5 should only be used once a day. It's not to be used 3 times a day.
Well, I'm glad you mentioned that, because there are weight loss programs in the community where patients come to me and they say, I participated in Medi weight loss. I got phentermine 37.5 3 times a day and I want it. And I say, whoa, hold on a second. So honestly, people are doing that.
But it's not recommended. I don't want this audience. Okay.
Understood.
Just it's very dangerous to do that.
Yes, right? Absolutely. Okay. Absolutely. So correct. Absolutely. You should not do that. The most that I would do would be, you could do 8 milligrams 3 times a day, or I might do 15 milligrams once a day with the possibility of adding a second dose, but not in a long term.
Yeah, I have a question for Dr. Jody. You showed us some data where you showed that 13% of people may not respond to semaglutide. Is there any way of determining beforehand who those non-responders could be? Are there any determinants which could actually predict the non-responders?
Right. So that, really, honestly, that is the holy grail question, right? If we could predict that. So not really. It's just as I said, early weight loss tends to predict longer term weight loss. I did a large study myself that was trying to look at predictors of weight loss with one of the earlier GLP-1 agents, exenatide, and we looked at a variety of different metabolic markers and did not find any. And so, to my knowledge, there really there aren't. And so I have though found that the initial slope, like of the weight loss curve, within really even the first 2 to 4 weeks, is a very good predictor. So, if you have people that have lost, 10 pounds in 2 weeks, those are people who typically are going to have a very nice response. If you're finding that someone is having has lost, really a couple of pounds over a month, that's a more modest response. So really, but as far as I know, and anyone should please chime in, there aren't any biomarkers that can predict right now who's going to be a responder or not.
Right. We have a live audience here with us listening into this lecture. And there is a question from this audience, and that is there any difference in response of weight loss in metabolically healthy obesity versus unhealthy obesity as far with the GLP-1 receptor agonists? It could be taken by anyone. Dr. Caroline, Dr. Judy, is there any difference in response of weight loss in metabolically healthy obesity versus unhealthy obesity with the GLP-1 receptor agonists?
I don't think the studies show any difference. In general, not really with it's true with any weight loss drug that the weight losses tend to be less in patients with diabetes than in patients without diabetes. But that is typically because some of these patients are on diabetes medications that reduce some of the weight loss that could be gotten without those drugs being on board. But I don't know of any study that show differences in weight loss and percent weight loss. Again, when you look at all drugs and you look at, that drug's effect on patients with diabetes and patients without diabetes, you tend to see more weight loss in those patients without diabetes for those reasons.
Anita, if you allow me, I agree totally with Dr. Abovian. We don't have studies that compare the efficacy in people with diabetes or not. But let me make a guess here. There are some studies showing that around 30% of people with diabetes have deficiency in GLP-1. This related to gene mutation in transcription 7-like-2 gene in chromosome number 8. And this had been confirmed in the cohort of diabetes prevention program in the Finnish study and also in the Indian prevention study. What I found in my practice is that those people who develop more side events at the beginning and even on a smaller dose, sometimes they respond much better. So I'm assuming that people who have deficiency in GLP-1 may respond much better and more, I would say, powerful than people who don't have that deficiency or genetic deficiency in GLP-1. And in my practice, I always insist on people who get some nausea or some vomiting at the beginning to keep on the medication in a very small dose, maybe on week on and week off until they get tolerated to the medication and then increase the dose. And I find very, very good results in those people who usually develop side events at the beginning.
Also, I would add that, oh, go ahead.
No, please go ahead.
I think that in some of the studies, if they stratify with the very, very high BMIs, so I don't know if you're going to call that, where you are on the spectrum of metabolically healthy or unhealthy obesity, but with BMI, say, in the high 40s or over 50s or into the 50s, those there may be a better response than people who have BMIs in the low 30s. But it's also, that's similar to say the glycemic effect you get if your starting A1C is 10 versus 8.
Hi, Jackie. This question is for you. Very often, resistance training in diabetes causes blood glucose to go high, which is very demoralizing for the patient. How would you manage this rise in blood glucose, or how would you titrate the exercise?
Great question. So first is it's really important to educate our patients about those changes in the glucose and how there's release of those counter-regulatory hormones and what the role of the liver here as well. So I think the key is to switch the order of the exercise. So there are studies that were done actually specifically with type 1. But I think it can apply to people with type 2 as well. So we'll have them perform a light warm-up and then get into resistance training and then finish up with their cardio exercise at a steady pace or at a light intensity. So then they'll be able to balance the glucose. So as the liver breaking down glycogen, release it in glucose into the bloodstream. So we see that increase. And then with the aerobic activity at a light up to moderate intensity, they'll be able to, the muscles will be able to utilize all that glucose. And then we could see a better balance in their overall glucose control.
I have a question for Dr. Aaron Price. We know about people, cognitive behavioral therapy and all of that, people who are in depression, but have you ever come across people who are on a program but actually lie about what they're doing with their diet and exercise just so they can shift the blame to somebody else?
So that they would say they're exercising more than they are, or that they're eating a healthy diet.
Yeah, willful lying. Yes.
It's not something I encounter that much. I'm sure it does happen. I find that people generally are pretty honest about what they're doing. At least that's been my experience in Why Wait, that people are often at a low point when they come to us. They're really kind of desperate for some kind of help. And so they're pretty open about what they're struggling with for the most part. I know Jackie or Dr. Hamdi have had experience with that. It's not something I've encountered so much.
I didn't.
Okay.
Sanjay, if you allow me, I would like to ask Dr. Abovian, in this part of the world, in India and also in the Middle East, people are jumping quickly to bariatric surgery. And bariatric surgery is very, very popular. And in reality, in some places, it is even number one procedure that is done in management of obesity quickly. So I would like to get your experience. When exactly you send your patients for bariatric surgery? And what you would advise people who are jumping quickly for bariatric surgery?
So we have Dr. Shashank Shah over here, who's a bariatric surgeon, and I'm sure he'll be able to give us a better answer. So Shashank, would you like to answer that question? You're muted, Shashank. Can you unmute yourself, please?
Yes. So very interesting question. Even though our guidelines and the government guidelines do suggest that anyone with a BMI more than 40 or anyone with a BMI more than 35 with significant comorbidities, which only include severe sleep apnea, coronary artery disease, cardiomyopathy, and uncontrolled type 2 diabetes. Only these comorbidities are recognized by our government, and recently in last 2 years, it is approved by insurance companies. On the contrary to what we said, we still find ourselves struggling to offer bariatric surgery to patients who are extremely deserving, even very, very high BMI. And I still believe, and maybe add a question here, would addition of this new holy grail delay decision of many of those who are morbidly obese or super obese? But it is not offered for everyone. Under clinical trials, maybe some of these metabolic surgeries were offered for type 2 diabetes, which in Indians is predominant and with a lot of central obesity and higher risk. But by and large, I follow that. We still follow the American guidelines for management of obesity, even though Indian guidelines should be at least 2.5 BMI lower than the American.
So back
Sanjay,
to
can I ask a question?
Yeah, very good. But back to Dr. Abovian, I would like to hear the American experience and the expert judgment.
Thank you, Dr. Hamdi. So in the United States, you know, bariatric surgery is offered, and we have many great programs that offer it around the country. And if you look at the statistics on a yearly basis, there are 250,000 procedures done in the United States per year. And this represents 2% of patients in the United States who would be appropriate candidates with a BMI over 40 or over 35 with one comorbidity. There are millions of Americans who meet that criteria, and only 250,000 procedures are done for extreme obesity. So if you were to say to somebody that this is what happens with, let's say, coronary artery bypass grafting, that you have all these people who have triple vessel disease and 2% get surgery, you would say this is negligence. But with bariatric surgery, our guidelines do not mandate that you must tell a patient with a BMI over 40 or over 35 that this is the procedure for you. You can, but it's not a mandate. And therefore, what I think needs to happen is we need prescriptive guidelines. Prescriptive. If your BMI is over 40 or over 35, the number one thing that you should do is bariatric surgery. Now, yes, it's surgery, but coronary artery bypass is also surgery. Plus, coronary artery bypass grafting has a higher mortality rate than bariatric surgery, which has a mortality rate akin to a cholecystectomy. So it's safer. So if you look at it from that perspective, we're not doing enough bariatric surgery in the United States. It is a procedure that definitely will get you at least 20% weight loss. Even more, the average for the Roux-en-Y is 33%, with the sleeve gastrectomy, 25%. So I think that we're not doing enough surgery in the United States, and I think that other countries are doing more surgeries, and I think that is appropriate. We don't do it quickly in the United States. There is at least a 6-month workup and the patient has to have tried lifestyle with medication or without medication for at least 6 months. Most programs look at that as well. Many of these patients already have had years of failures of medical treatment. So the reason why so few procedures are done in the US is not guidelines. It's the patient does not want the surgery. When I tell a patient, you know, I prescribe it often, and I often get, doc, I know I can do it on my own. I don't want surgery, or I don't want the easy way out. So we have quite a stigma in the United States. We still think, many patients still think that this is a matter of their own willpower, that they can do it on their own if they just tried hard enough. And so I think that it's a great question. We still have a ways to go.
Very well.
Thank you so much. Riveting as this panel discussion is, I think we need to close due to lack of time. We have some other exciting obesity talks lined up. And therefore, I would have to close this particular panel discussion. I'm sorry for that, but I'm sure at some other time we'll be able to take that up. So thank you very much, speakers and panelists, for this wonderful discussion and interaction. Thank you for being here with us.